Hello and welcome. I'm Elisa Hernandez, a librarian at Stanford Health Library. Thank you for joining us for our talk, Medical Aid in Dying in California's End-of-Life Option Act. It's my pleasure to introduce our speaker, Dr. Joshua Fronk. Dr. Fronk is a clinical assistant professor within the Division of Primary Care and Population Health at Stanford University. He works as both an inpatient and outpatient palliative medicine physician at Stanford Health Care and is the medical director for the outpatient palliative care program, which has expanded to multiple clinic locations across the Bay Area. Areas of interest and expertise include communication training for healthcare providers and working with the young adult population living with terminal illness. Throughout the talk, please enter any questions into the Q&A box at the bottom of your screen, and at the end of the talk, Dr. Fronk will answer as many of those as possible. Over to you, Dr. Fronk.
Welcome, everybody. I'm glad to be here and to share this really important topic. I think this is an item of interest that comes up periodically just in the general community, but also I think in the medical community, I think there is questions that this topic brings up. And so I'm glad we could present this today. Just kind of a roadmap of kind of what I envision as we cover this topic for the next hour. I do want to spend a little bit of time talking more about what palliative care or palliative medicine is, just because I think that's still an area of medicine that people have questions about. We will talk about medical aid in dying and how it differs from other options at end of life. What are the steps that one would need to do to pursue medical aid in dying here in the state of California? What other options exist if this is not an option that's appropriate for you? And then talking about how patients and families can really protect their goals, their values, and share that with their medical teams. So first, a little bit about what palliative care is. I'm always fascinated in my clinic when patients come in to see me. Usually the first item of interest after introductions is, what do you do? And I'm always very fascinated by patients and their willingness to come and see a physician and not really understand what they're getting themselves into. I don't know if I could do that. But palliative care is kind of a newer specialty. It's been around now for several decades, but fairly new in comparison to perhaps other specialty groups. We are a team led by physicians, but we partner with our APP colleagues, nurse practitioners, clinical nurse specialists, physician assistants. We have wonderful social workers, chaplains, nurse coordinators, and even medical assistants that help us provide the care that we do. And we provide a very important layer of support for patients living with serious and terminal disease. Sometimes hospice gets misconstrued as palliative care as being the same. I often think as palliative care is something that should be given to anybody who's living with a serious illness at any stage, whereas hospice is really specifically about the end of life, that last 6 months of life. So if you think about the goal of hospice, it's about comfort and maximizing comfort. Whereas palliative care, we are champions also of patients seeking curative treatment. And we also say you should also still have comfort. So it's kind of a win-win. You should have quality of life and quantity of life. And so that's kind of one of the distinctions between us and hospice. Here's another way to kind of think about what we do. And you know, in short, I think palliative care, we are kind of the quality of life experts. We kind of take a step back and really help patients and families, their loved ones, really kind of manage the day-to-day stuff that comes while they live with a serious disease. I'll use an example of cancer, since I see a lot of patients with cancer in my clinic. And with that comes a slew of different physical symptoms. Sometimes it's pain, sometimes it's not. Sometimes it's more nausea or constipation issues. And it's not just the physical complaints from the disease that can be a problem, but as patients are seeking out chemotherapy or targeted therapy, there may be side effects. And so we also help decrease the burden of those side effects, which ultimately helps patients get more treatment. So that kind of goes back to that win-win kind of mentality. Sometimes it's not just the physical complaints that patients have, but kind of more the mind effects. And for me, this is kind of more we see more patients with anxiety, depression. Sometimes it manifests itself as, gosh, I can't sleep. I have really bad insomnia now. And so that's an important part. Like, you could imagine if you can't sleep, how much that impacts your quality of life. And then again, like as a person living with a serious disease, you're not the only one living with this. Your partners, your caregivers, your children, your parents, like depending on kind of what your living situation is, they too are going to be dealing with a lot of change. And so really helping manage the distress that happens for our families and loved ones is really important. And so our social worker team plays a very important role here. And then finally, I think a really important part that we strive to embrace is kind of the spiritual realm of health. And I remember when I first started in medicine, I used to always kind of cringe by that term, like I don't do spiritual stuff. But the secret is we do. When you are dealing with something as profound as end of life, there is no way you can go through that experience without having some degree of existential or spiritual distress. Questions around, why is this happening to me? What happens next? What do I do if this treatment doesn't work? Am I dying? And those are all really big questions and very important questions. And so a lot of and honestly, it's probably my favorite part of the work I do is just kind of really stepping into that space and allowing patients and families to talk about the hard things. That's the best way I can describe palliative care. It's all of that. So some quick kind of fun facts about death and dying. Everybody, if you live long enough, you're going to be faced with decisions around aggressive interventions. What things do you do? What things do you not do? No surprise, everybody, including myself, we will die one day. And I think sometimes in medicine, we try to ignore this. We don't want to talk about it. We don't want to think about it. But the truth is there, for everybody, there will come an end. And so we do a disservice by ignoring these important topics and not really exploring like how do I want my end to look like? And I put in here, choosing not to talk about death, not going to prevent it from happening. It still will happen. So transitioning into our main topic for tonight, which is medical aid in dying. I chose this title versus sometimes you'll see in the internet world and in medical literature, the term physician aid in dying. And I prefer this one just because everything we do in medicine carries a team. And I think it's very easy for physicians sometimes to feel isolated, like somehow they're the ones carrying the sole burden. And truly, it shouldn't be. It's us as a team helping patients go through this process. So that's kind of what I'll be referring to for the rest of the presentation today. Medical aid in dying, just as a definition, it's essentially where a physician will provide to a patient who has capacity and is living with a terminal disease a prescription for a medication that is lethal that then the patient can then choose to ingest and end their life. This is not euthanasia. And I think that sometimes comes up. People will use two terms interchangeably or think of this as euthanasia, and it's not. Euthanasia is illegal in the United States and all the states. And what this would involve is the actual administration of a medication by a physician or medical team with this purpose of causing the death. And so we won't be talking about that today because it is not legal here in the United States. Here in California, they passed a law called the End of Life Option Act. I included these two acronyms, which again can sometimes be confusing, but depending on where you look, it may be referred to as ELOA or EOLOA. Essentially, it's all the same thing, but it's the name of the actual law that got passed in June of 2016. There were some revisions made to the law in 2022. Those revisions involved changing some of the waiting periods that patients had to wait for. It also removed a lot of extra steps around documentation that really didn't help aid the process. And then just as to cover everything, there was actually a recent bill, California Senate Bill 1196, that was recently just withdrawn last month. But this was an attempt to further kind of expand what the original law allows for. The current law as it sits now is supposed to sunset in 2031 unless it is further extended or changes are made. It's estimated about 5,000 medications have been prescribed here in California for people who took advantage of this law. Now, out of those 5,000, not all of those are actually ingested. So what are the requirements? What would a person have to do? Why would they be eligible? The first being you have to be an adult. This is important because sometimes I see patients who are 17 or 16 and are living with a terminal disease, but they are not yet of age where they are considered an adult. So they are not eligible for this. People here have to be a resident of California. You can't just be a traveler or someone passing through. I have seen when this comes up as far as how do you prove that you're a resident. It can be just a California license. It could be registered to vote in California. It can be also proof of homeownership or even a tax return. So those are the various ways that someone could prove that they're a resident of California. You must have a diagnosis of an incurable or terminal disease and a prognosis of less than 6 months. This is really important because this is the same criteria that is used for people to be enrolled with home hospice. So when I see a patient and they ask me questions about this, and I respond by saying, "Are you ready for hospice?" And they say, "Oh, no, Dr. Fronk, I'm not there yet." Then they're not ready yet to start or pursue this process because the requirements are the same. Patients have to have capacity. They have to be able to show that they have capacity to understand ramifications of decisions. This is important in case of situations where perhaps maybe someone's had a massive stroke, they no longer have capacity. Family members cannot step in and make this decision on their behalf. Surrogate decision makers can step in and help make decisions outside of this, and this happens all the time in the hospital setting. But when it comes from medical aid in dying specifically, only the individual pursuing medical aid in dying is able to do it. Patients have to show that they are doing this on their own, that there's no coercion or influence of others. And in fact, one of my roles as a consulting physician for this process here at Stanford, one of my steps is actually having family members step out of the room and just to verify that the person is acting on their own accord. And then the final piece is patients have to be able to self-administer. This does come up periodically where maybe someone has lost the ability to swallow and other family members or loved ones can't force this in, like the patient themselves have to be the one to do the administration part. So what are the teams? Who's all involved on the medical side for this? It does require 2 physicians licensed in the state of California. Not all California licensed physicians have to participate. So physicians are allowed to conscientiously object if this is something they do not want to participate in, and that is allowed. One of the new changes in the law that took place in 2022 was this requirement that physicians who are choosing to abstain, they are supposed to document in the medical record that they are abstaining and that they have clearly told the patient that they will not participate. This is important because that first kind of visit, as long as there has been a true informed decision made, and it's clearly just the physician not wanting to participate, that first oral request could be considered the first request. If not, it may be considered just like an informational inquiry. So the documentation really does help if a physician chooses to step aside. The attending physician or the prescribing physician is, in the state of California, is the physician who's primarily responsible for the treatment of the patient's terminal disease. This can be a primary care physician, so a family physician or an internal medicine physician. In specific specialties, it's usually the supervising physician. So in oncology, it's called the oncologist. With patients with ALS, that's usually neurology. And that's important because they actually have the most expertise dealing with their certain illnesses. A consulting physician is someone who's totally independent of the prescribing physician. And this is someone who has, qualifications to help make assessment around prognosis, as well as making assessments that patients have capacity and that patients have had the opportunity to talk about other options. And so that's often where I will step in as my role as a palliative medicine physician. Either the attending physician or the consulting physician may choose that a mental health specialist is indicated. I feel like I don't see this often, but these are often cases where there is perhaps past attempts of suicide or really severe mental illness, psychosis, schizophrenia. Like that's where we would want perhaps to have a further evaluation to make sure a person really truly is making the decision and has the capacity to do so. The attending physician has to visit with the patient 2 times, once for the first initial visit, and then a second visit later on. And then there's documentation that has to be completed by the patient, by the attending physician, and also the consulting physician. And all that documentation needs to be uploaded to a California database. So here is a kind of a diagram, just to kind of outline like what this would look like in real time. The first step is that first oral request from a patient. I would say that most of the time, patients asking for this or about this, it's often just an introduction. But it can be the first time when a patient really truly is starting the process and wants to go through it. Patients have to do a written request in addition to that oral request. And there are kind of official paperwork that you can find on various websites. I know like our clinic, we carry them that patients can have. But essentially, it's very similar to like an advance directive in that you're specifically requesting that this is something you want to pursue. And just like an advance directive here in the state of California, it requires either a notary or 2 witnesses. The second oral request, a second meeting with the attending physician, and it is important to note here that both requests do not have to necessarily be in person. One usually is, and the other one could perhaps be a video visit if the attending physician is okay with that. or even sometimes maybe perhaps a telephone visit and then a subsequent visit thereafter. One of the changes in 2022 was this time frame. Previously, it had to be 2 weeks, where patients would want to start or initiate this process and would have to wait for 2 weeks until they came and were eligible for the second visit. Now it's at least 48 hours, and it's the minimum 48 hours. I think that's important, just because, as I'm sure many of us here on this call this tonight of experience, like sometimes it can take time to get into physician's office. And especially where this is a physician-only type of responsibility, it may not be 40 hours. It may be more like a week. And that's really just dependent on kind of like clinic availability. A consultation with the second physician, we talked about that role is specifically just to confirm the diagnosis, the prognosis, make sure capacity is clear. These two things can be flipped. So the consulting physician could see the patient right after the first oral request, and then they see the second visit with the prescribing physician. So there is no specific time frame that these two have to happen in this order. And sometimes it works out where patients could get in, for example, to see me, but then I can see them sooner before they can get back in to see their primary prescribing doctor. And then, like we said, depending on either two physicians, if either one feels a mental health specialist is needed, then that would also have to take place. After that's all completed, then the medication can be prescribed to a pharmacy. Usually this is with a compounding pharmacy, just because of the medications that are utilized often are different kind of combinations. And so they're the ones that will then actually compound the medication for patients. And then after a patient chooses to ingest the medicine and dies, the prescribing physician is required to do some follow-up documentation, and also make sure all the paperwork that has been completed, it gets uploaded and is tracked. I do want to point out, if you notice on this kind of graph, I didn't specifically list out, when a patient would ingest the medicine. And I didn't do that just because what we find is anywhere along this arrow, patients will choose sometimes to stop. And patients may start the process and meet maybe with the consulting doc, and then afterwards say, no, I really don't want to do this. Patients may actually go all the way through and get the medication, have it, and still not choose to take it. And that's okay. At any point along the process, patients they can act voluntarily. They can always step away if they decide they don't want to continue through. So what are some of the challenges? I think, one of the biggest things, and I'll probably say this multiple times tonight, so I apologize if I sound like a broken record, but communication. So many times, patient requests around medical aid and dying or asking about it really are mass requests around wanting to talk about end of life, wanting to talk about what the dying experience is going to look like. And we kind of live in a culture where death and dying is it's like hidden. We don't talk about it. We pretend it's not going to happen. And when you're living with serious illness, what I have seen over my career is everybody at some point along that way starts to think about the hard stuff. They start to worry about my loved ones when I'm gone. Start to worry, like, what does it really mean to be dead? And, those are very real. And I think it's important that I think one of the things that medical aid and dying has done is I think kind of at least brought forward a little bit more how important these conversations are for patients and for families. I think it's important to just recognize that medically aided dying is just now a potential legal option. It's not the option for everybody, but it is a option. And I think, for some people in the medical community who really struggle with this, it is the world we live in now. And so I think it's important to really kind of think about like how you feel about your own mortality, and obviously how you feel about caring for other people who are facing end of life. One of the hard pieces I think that we've seen and learned and here in California, when you compare the rollout of medically aided dying, say, to Oregon, they've had theirs in place since like 1997, is we didn't have like a statewide patient physician advocacy support network. And I think that was a disservice. In Oregon, there is a nonprofit group that is there to support patients to get connected with physicians who might want to participate. And it was also a place for physicians who are maybe struggling with, I don't know how I feel about this. I don't know what the medications are. It was a place for them to also find support. And so over time, we've seen kind of groups kind of form that have been helpful to kind of help fill this void, but it's not like a universal statewide option. And so really it does depend kind of on where you live. But a couple really good resources, End of Life Choices California, which is a nonprofit group. And then one of my favorites, Compassion and Choices, which is also available. This does create sometimes tension between patients and their medical team. Physicians, can and should feel okay to opt out if this is truly something they ethically feel like they can't be a part of. It's important for physicians to practice the way that they're going to feel comfortable practicing. However, I would argue they also have a responsibility to their patients to help them understand maybe what their prognosis is and help walk them through anticipatory guidance with death and pass them off to maybe a colleague or someone who is willing to step in this role. I think honestly, one of the things for me personally, and I really encourage whether you work in the medical community or just an everyday person, to really kind of think about how you feel, how you really want others to kind of respect you as you approach your end of life. And honestly, I feel like when this first started coming up, I can remember going to some conferences before the California law became valid and just seeing how torn, even within my palliative care community, people were and the mixed feelings. I don't think it's something, I think maybe on paper, all of us say, well, yeah, this makes sense. People should have autonomy. But for some reason, it does feel a little different. And it's very easy to look at it with a different lens. And it does require you to kind of do a lot of self-reflection. I feel I am very grateful for some of my patients because they have taught me a lot. And I feel like they are the ones that have really provided me, perspective on when this tool may be the right tool for some people. I'm going to share a clip. One of my patients, who was actually one of the early adopters of medically aided dying, partnered with Mercury News here in the Bay Area and actually allowed them to come in and film her last day as she was choosing to take the medication that would ultimately cause her death. And so I'm going to share that now. I just want to highlight my favorite part of the video. And it's actually about halfway through. And I don't even think the people at the Mercury News totally understood what they captured, because there's this beautiful moment between Jill and her partner where she comes and joins him on the couch, and you can see this picture here. And it's just this beautiful moment of her playing with his hair and looking at him in this beautiful, loving way. And at the same time, him, who's obviously wants to support her, but is obviously grieving and struggling and knowing that this will be the last day that they'll be together. So anyway, I will play that now.
Love you, Jill. You are awesome.
You too, love you. Thank you.
You have been so awesome. In this neighborhood, man, you are the queen.
Thank you.
Thank you. We owe you so much.
And especially now, because there's this tea revolution going on.
Dig in. Dig in. Dig in. That's my speech.
It looks like sugar.
Today we're celebrating your birthday.
And her death.
Is that...
And if that sounds weird to people, it's a celebration of life, you know? She gets to, one of the odd things about this whole event is that we've been grieving before. Sometimes you lose somebody and then you grieve. You don't know it's coming and it happens, or it happens, you know it's coming and it happens really quick and boom, it's done, and you're grieving. We've been grieving for a long time. One of the things about Jill is you see her on her appearance and you don't think she's so sick. It's so very deceptive. It's been deceptive the entire time. But inside her body is shutting down. And the last time we went to see her doctor, you know, he pretty much confirmed what we suspect. Her body is shutting down. And he said things are gonna happen faster now.
Tired because of all your
Tired.
medications, huh, Jill?
And just life. Fighting the cancer, I think, is #1 on the list.
We did have a scary incident a couple weeks ago. It scared her. And that was when she wanted to really get her medicine to have on hand. The date had been talked about prior to getting it, because it was like, well, once we were going to get it, we knew it was going to be within, it's got a 2-week shelf life. So we knew it's going to have to be within a couple weeks. And I thought it was selfish of me to be holding out for my birthday and our anniversary.
You are opening up your story to us and the readers. And what would you like them to know about?
Oh, how incredibly grateful. I am that I have this.
This law to take advantage of.
Can I imagine not having this?
Okay. It would mean to you not to have this.
It would mean terrifying.
Okay.
Just utter terror.
I want her to enjoy her life for as long as she can, whatever it is. If it's an hour every day, and she's enjoying that hour. But then again, it's her choice, and I would never try to influence her, but I do think that life is precious.
This is choosing compassion for herself. This isn't somebody saying, you need to do this, you need, this is something she wants. She wants a peaceful, gentle death.
There has been a light, a load off the shoulders a little bit that this decision's been made, that she is going to end her suffering and join the universe, and I'm happy for that. I know it's strange, but there's some happiness to it too.
And no dental appointments.
Oh, that was the first thing I did was cancel all dental appointments. Hell yeah. Hell yeah. I'm looking forward to taking a nap. That's the way I'm looking at it. This is just like right now it's a nap, and I'm looking forward to my nap.
She wants to take the pre-meds now, which means in 1 hour she will take the other medicine.
Now I feel a little wimpy, like I'm avoiding all the potential subsequent pain.
But I love Jill, and I will love her until she dies, and after she dies, I will remember her and keep her in my heart, and I'll smile from time to time when I think about her, and that's all I can do.
Where
more importantly, don't tip her wine over.
I think that video just, I think, encapsulates exactly, I think, you know, it's never easy whether a person chooses to die with this or whether they die in the hospital from natural causes. I think it's always hard. You know, I think not to just to protect her and, you know, patient confidentiality. The only thing I'll add is Jill loved life, like 100% loved life. And this had nothing to do with being suicidal or not wanting to be alive. She very much did. And it was really just, I think, you know, accepting what I think all of us at some point has to accept. And that is that time is short. And, you know, we all are living the rest of our lives, even today. I do want to point out from that video, just because I know I haven't covered it, but they mentioned just more of a logistics that, you know, she was going to take her anti-nausea meds, and that's actually part of the regimen, is taking at least a couple anti-nausea meds an hour before you ingest the medication. And that's just because your body naturally is going to try to make you throw that up. And so it's kind of a protective measure to make sure that you don't vomit. The other piece that I think is a misconception is this idea that a person will drink the medication and go to sleep and be dead fairly quick. And actually, there's huge variation with the time frame from a person when they first fall asleep to when they actually die. And there's actually some documented cases out of Oregon where patients have lived for close to 72 hours after falling asleep. So it's not this like quick death. The one thing I think that people can get peace from is that in the cases where that was the case, none of those patients woke up once they fell asleep. They were asleep and comfortable up until the end. So what about other alternatives to medical aid in dying? You know, what else is available? First and foremost, start a conversation. I can't emphasize how important that is. And this is so important if you as a patient, you're thinking that this might be something you're going to pursue in the future. Start talking with your doctor, your medical team, way upstream. I think the one time where I find where there's added stress when people are trying to pursue down this path is they wait too long to start talking about it. And it's way easier to ask your physician upstream, will you prescribe for me when this time comes? And the phrase I tell my patients is you need to ask, will you prescribe a medication that will cause my death when that time comes? And it's okay if the answer is no, right? That is okay. But what that does is it offers you the opportunity to then find a physician or to be transferred to a physician who is willing to participate. If you wait too long, that window you may lose. Consider seeing palliative care. I do this all the time. I love doing this. There's something about this work that truly feels like, you know, it's what I was meant to do. I feel like I learn more from my patients than perhaps that they learned from me. I feel like I become a better physician as I help people navigate these really hard conversations and discussions with their family. And it makes me think about, well, what is it going to be like when it's my turn? Because it will be one day. I'll be approaching end of life. Complete your advanced directives. I think that's really important. And I have another slide that that'll talk a little bit more about that. Enroll with hospice. If you are even considering medical aid in dying, do hospice at the same time. There is no downside and there's only benefit. Similar to asking physicians if they're willing to prescribe, it's also important to ask your hospice agencies if they're willing to at least participate. Are they willing to, be available when you choose to take the medication? Some hospice agencies may be affiliated religiously and they choose to not participate. So that's important, as you're thinking about enrolling, that you find an agency that will support you. Palliative sedation. This is something I feel like that's kind of become much more okay. It used to be kind of what medical aid in dying is now, where that's kind of like the taboo topic. But this is what we do all the time in the hospital when we have patients and we're sedating them on a ventilator to keep them comfortable. We can do proportional sedation where, depending on how bad their symptoms are, we can keep increasing sedation with the goal of keeping them comfortable. And when they're in that place, they aren't drinking, they're not getting nutrition. And so it does. Ultimately, patients will die, but that is not the intent. The intent is to relieve suffering, and palliative sedation is legal in any state, in any county here in California. Voluntary stop eating and drinking. This has probably been something that people have thought about since the beginning of time. You have a true ethical principle of autonomy. You can make decisions for yourself. And you can choose to stop eating and drinking. I would, depending on where you're at, kind of in end of life, it may take a little longer. But this is also one of those things that, I would encourage people to have hospice or a palliative team, someone involved that can help you manage some of the symptoms that this will bring up. But it is something that is available, and Compassion and Choices, which is one of those sites I talked about earlier, they have some really good videos and information about this if people are curious about hearing more. And then finally, I put withdrawal of life prolonging interventions, which is also available and has always been available for people. No one can force you to do a life prolonging intervention if you choose not to do it. So this too, sometimes we see in the hospital setting, if a person is on a ventilator and they're like, I don't want this anymore. All right, we can turn it off, and we should turn it off because that's the right thing to do. We should also make sure that we're treating their symptoms and that they're comfortable and they're not in distress once we take off that life prolonging intervention. Another intervention that sometimes people don't think about is like hemodialysis. Hemodialysis for patients with kidney failure is prolonging life, and patients with that can always choose to stop hemodialysis. And usually it's kind of one of those type of disease or death trajectories where people lose energy, slowly fall asleep, and usually around a week or less, they will die. But withdrawal of life prolonging interventions is always available. I think these are important too, because if you're going down the process of maybe pursuing medical aid in dying and something happens, something changes, and you can no longer participate, these are the other things that are equally available and really can be offered outside of this. Advanced care planning, like this is really important to really identify what your goals and wishes are talk with family. Yeah, it's important to write this stuff down, but it's equally, if not more important, to share with family members, loved ones, your physician teams, your medical teams, so people know what you're thinking about. And again, we don't give space to talk about death and dying usually. And so sometimes it's just opening the door and then allowing further conversation in the future. Your advanced directives, I put a little bullet in here for dementia provisions. This is kind of a newer kind of addition that I'm seeing more in the advanced directive that's very specific for what patients suffering from Alzheimer's or dementia will experience as that disease progresses. And it's a way for you to be very clear, like, look, if I no longer open my mouth when you try to put a spoon near my mouth, stop feeding me. If I can no longer speak more than a couple words, stop feeding and hydrating me. And so you can be very specific upfront about what your wishes are and making sure like your surrogate decision maker is going to honor your wishes when you lose your capacity to make those decisions. This bright pink form, the pulse form, this is your backup plan, 100%. So patients who may be interested in medical aid in dying, but they don't quite qualify for that 6-month window, do a pulse form. You don't have to be 6 months or less. And this is a way to really protect yourself that basically says that when you have a natural death, let that be your natural death. Don't do chest compressions. Don't do crazy stuff. Don't do intubation. And so this is a way to protect yourself. And in fact, it's also a way for sometimes I screen patients. When they bring this up, I say, well, let's fill out a pulse. And they'll say, well, I'm not ready for that. I'm not ready for that. Well, then you're probably not quite ready for medical aid in dying either. Because, you know, it doesn't make sense to still want intubation, whereas you're also seeking control over the dying process. As we're getting close to the end of time, just a couple of frequently asked questions, and then we can open up the group. You know, patients with early dementia, you know, can they prophylactically plan for medical aid in dying? And currently, no. Because the law is very clear that patients have to be in that 6-month window. And unfortunately, with dementia, it is one of those terrible diseases that when people are actually in that 6-month window, they no longer have capacity to make this decision, which is why I think it's important to be very clear in your advanced directive and really look at using those extra resources, the dementia provision. There's again, compassion and choices have a really good, you can just print it out and include it with your advanced directive. It's a great way to cover kind of what your wishes will be in the future. Another question that comes up all the time is, well, what will happen with my death certificate? If I choose to ingest, what will it say? And that was actually something that was very clearly written in the law, that death certificates will list the qualifying disease as the cause of death, not the ingestion of the medication. So in the case of a patient with ALS, if they choose to take the medication and die, the death certificate ultimately will say they died from ALS. And with that, we have about 5 minutes or so for some questions. My one ask for everybody, if you wouldn't mind, just because we're always trying to get feedback on these presentations, and I would love to hear from you about what was helpful, what maybe you would like to see in the future. So please, if you wouldn't mind doing that for me, and then I can open it up to questions.
Thank you. We have a few questions in the chat. If anyone else has questions, please enter them in the Q&A form. First question, could you have palliative care and hospice concurrently?
Yes. And in fact, many of my patients who I see in palliative care, you know, when they get close to enrolling in hospice, I have some patients who actually choose to have me continue to follow them as one of their hospice doctors. They always will have a hospice medical director who will supervise the team of hospice, but you can always specify having another physician involved, and oftentimes I'll continue to follow them.
Thank you. Hospice is a federal program, and so it has federal restrictions, such as no cannabis prescriptions. Is palliative care federal as well and subject to the same restrictions?
So I've never heard that specifically. The only time I could see where that could potentially being an issue is if hospice was taking place on like VA property. The VA is under federal law, and so they still continue to see cannabis under a different category. But really, it's more once most hospice actually takes place in your home. And so in your home, you have full right to do whatever you want in your home, like it's your home. And so it's really only if you're living in a facility that is federally guided.
Thank you. My father died in his 90s in palliative care post-stroke with 0 water or food since he did not want tubes in advance directive. He did want water, but they would not give him any, and seemed sorry, this was just a comment, not a question.
Okay.
Next question. How do death doulas factor into this?
I mean, I see death doulas as kind of being an ancillary team member. So similarly to many of my patients who have home hospice, sometimes we'll hire an outside nurse to come in and provide extra nursing care on top of what the hospice team does. And so I feel like death doula kind of have that same role. They're not going to have all the extra resources that a hospice team is required by law to provide. And so I see it kind of as being a complement.
Would you be able to share the names of the 2 nonprofit support groups that you mentioned?
So the one is Compassion and Choices, and it's California based. They have actually theirs is really good because they actually have a section that's actually been translated into Spanish. So I really like that they're trying to be more broad with everybody. And then the other one is End of Life Choices CA.org. The other great one that's not within California, but is the Oregon group. And they have a lot of resources that are available. I can't remember them off the top of my head, but they have a lot of good resources as well.
What is the best way to find a cooperating doctor if my primary care physician does not want to participate?
Oh, yeah. I mean, most groups, are basically like Stanford, for example, is what we call an opt-in institution, which means if patients are previously established with Stanford and their primary physician or primary specialist physician elects not to participate, then we have through our different various divisions a process where patients can then be connected with a physician who would be a prescriber. Honestly, I feel like I have total respect for so many of our primary care doctors. Sometimes when specialists are saying I don't want to do this, I applaud my primary care physicians because they often will step up and say, I know this person, I know them, I will do this. So honestly, I feel primary care is a great place if you feel like you're hitting a wall with your specialist physician.
Well, thank you, Dr. Fronk, for sharing this great information. And thank you to our audience for joining us and for the great questions. If you'd like additional information or resources, please reach out to the Stanford Health Library. And we hope you'll join us for our next lecture.
Thank you, everybody.